Hello, my name is Rachel Pearson and I'm a research assistant at University College London in England. And today I'm going to be presenting work where we used linked administrative health and family court data in England to evaluate maternal mental health related risk factors for women returning to court and having repeated child removals. So since 2010 in England, the annual rate of entry into care has increased by about 10%, although this rate of increase does vary quite considerably by region. And children can enter care via several different legal routes, with the most common routes being one, via out-of-court arrangements between a local authority and parents, often termed voluntary agreements, and two, via the family courts, via court proceedings known as care proceedings, where a family court judge decides whether or not a child should be placed into care to safeguard it from significant harm. So in England, the number of applications made to instigate these care proceedings has grown quite considerably since 2010 by 70%, which has added additional pressure to the family justice system. So researchers using family court data have estimated that around 1 in 4 women involved in care proceedings will return to court within 7 years for a subsequent set of proceedings. And these returns to court are largely characterised by women returning quickly with an infant born following a previous set of care proceedings. And this leaves very little time in between care proceedings and having a new child in order to address barriers to parenting capacity. So healthcare need related to mental health and substance misuse is very common among women who return to court and may be amenable, at least in part, to improved healthcare intervention. However, in England, there's very little quantitative evidence on why some mothers with healthcare needs turn to court while others do not. And we also know very little about why some mothers with healthcare need have children removed from their care in the first instance, while others do not. In addition, a recent review of the children's social care sector, called the Care Crisis Review, highlighted the need for more and improved multi-agency working between health and social care services in order to support families where parents have healthcare needs that affects their capacity to parent, particularly where parents have mental health care needs or alcohol and drug misuse problems. So the aim of the study was to evaluate court and health-related risk factors for returning to court with a new child among women who are already known to mental health and substance misuse services. So here a new child is defined as a child born since the end of a previous set of care proceedings. So until now, England hasn't had any linkages between family court data and healthcare data. So we established a new linkage between administrative data from CAFCAS, who are the Children and Family Court Advisory and Support Service, and who are involved in all public family court proceedings, including care proceedings. So CAFCAS collect data on care proceedings, such as dates and legal orders, and they also capture all adults and children who are involved in proceedings. So crucially, they capture relationships, which allows researchers to follow family groups as well as individuals longitudinally in the data. So we use deterministic linkage to link this data to mental health service user records, just for women who are involved in care proceedings in areas where the mental health services were solely provided by the South London and Maudsley NHS Foundation Trust. So SLAM deliver a wide range of specialist mental health and substance misuse services to a population of over 1.3 million people. They also provide psychological therapies such as cognitive behavioural therapy to their population, allowing self-referral for common mental health disorders involving stress, anxiety and depression. So SLAM has captured data on all services since 2007, but there is some patchy data on service use before 2007. So 3,226 women were involved in care proceedings in areas where mental health services were solely provided by SLAM between 2007 and 2019. So of those, 71% had their first recorded or their index sets of care proceedings in one of these areas between 2009 and 2018. And we restricted it to these dates to allow for adequate data to look back in women's records and to look forward in their records from their index set of care proceedings. So 2/3 of these women linked to a SLAM service user records, indicating high burden of mental health and substance misuse problems among women who are involved in care proceedings in South London. We then excluded women who returned to court within a year for 2 reasons. So first, women who are involved in care proceedings who are pregnant during those proceedings will almost inevitably have their newborn child involved in care proceedings once they're born. And care proceedings can only be brought once a child is born. Often these care proceedings for the already born children and then for the newborn child are often consolidated, and it's very difficult to disaggregate these 2 cases in the data. Also, we need to allow enough time for women to get pregnant and have another child, because if a woman is involved in proceedings with a very young child, they obviously need enough follow-up time to account for the 9 months of pregnancy. Secondly, we really wanted to understand what the risk of returning was for women who had had enough time to engage with services following care proceedings. Care proceedings often facilitate engagement with mental health services. And then we also excluded women who were not known to services, so mental health and substance misuse services, before 1 year post onset of proceedings, so that we could identify women who had mental health need proximal to their index set of proceedings. So amongst the study cohort, many women were quite young at their index set of care proceedings, so around 1 in 4 women were under the age of 25 years old. Women from Black and minority ethnic populations were really overrepresented in this data, so only 48% of women were from a white ethnic group. And many women had a young child, so an infant under the age of 1, involved in proceedings. And most women had at least 1 child, either placed for adoption, placed into out-of-home care, or with extended family. 90% of women were already known to SLAM services, so their mental health and substance misuse services, before their index set of proceedings began. And around 20% of women had at least 1 psychiatric inpatient admission in the 2 years before and the 1 year after the beginning of their index set of proceedings. Most women had at least 1 psychiatric diagnosis recorded in SLAM, so about 30% of the cohort had a diagnosis of a psychotic disorder, around 20% of women had a diagnosis of personality disorder, and other common diagnoses included anxiety disorders and depressive disorders. Around 1/3 of women had diagnoses in their SLAM records which related to substance misuse, and 3% of women had a diagnosis for an intellectual disability. So overall, we had just over 5,000 person years of follow-up, and the median number of years of follow-up for women was 3.38 years. So around 13% of the cohort returned to court with a new child, 59% of which returned with a newborn infant, so under the age of 4 weeks old, and 92% of which returned with an infant, so under 1 year old. So women were typically returning with young children. So when we look at the cumulative hazard of returning to court with a new child amongst the study cohort in the first 5 years of follow-up, we can see that the cumulative hazard increases much more quickly in those first 2 years, which highlights that most returns in this study are happening quite quickly. So within the 2 and 3 years post the beginning of their index set of care proceedings. We then explored how this cumulative hazard varied by the number of outpatient attendances women had in the 2 years before and the 1 year following the start of their index set of care proceedings. So we used arbitrary cutoff values based on the tertiles of the distribution of outpatient attendances. And here this plot basically shows that there's a trend towards women who had more outpatient attendances over the 2 years before and 1 year after onset of proceedings, had a lower hazard of returning to court in that first 5 years. So finally, we modelled all the variables using Cox proportional hazards models, and we reached our final model after investigating the linearity of continuous variables and model fit diagnostics. So amongst the study cohort, being older, having an anxiety disorder diagnosis, or having more outpatient attendances were all associated with a reduced hazard rate of returning to court with a new child, while having an infant involved in care proceedings, losing custody of at least one child in proceedings, and having an intellectual disability diagnosis were all associated with an increased hazard rate of returning to court with a new child. We also found some trends in the estimates and the confidence intervals for some of the psychiatric diagnoses, although there was no evidence of an effect. So, for example, having a psychotic disorder diagnosis was generally consistent with having a lower hazard rate of returning to court, whilst having a personality disorder was generally associated with having a higher hazard rate of returning to court. But we found there was no evidence for these associations. So the key findings were that the strongest predictors of returning to court were having a new child, of returning to court with a new child were loss of custody at index set of care proceedings, or having an infant involved in the index set of care proceedings. We also found trends in the coefficient estimates, which suggested that different psychiatric diagnoses may have different risk profiles for returning to court. And then finally, we found strong evidence that holding all other covariates constant, women who had more outpatient attendances had a lower hazard rate of returning to court with a new child. So there are limitations, obviously, to this piece of work, namely the small sample size, which gave us limited power to detect associations between the variables in the analysis. The study also has potentially poor generalizability to the rest of England because it's just one small location. And obviously this work would benefit from replication of these results in different areas across England. It's also potentially limited by linkage error, because we found that women who returned to court generally had better recording of their personal identifiers and therefore were more likely to link to a mental health service user record. So further work using this study cohort will include linking in data on live birth using hospital records to be able to understand whether among women who had another child, does delayed pregnancy moderate their risk of returning to court. We're also working on getting linked data on hospitalisations for all women in England who are involved in care proceedings, so that we can replicate this study using hospitalisation data rather than mental health service user records in different areas of England, and also looking at the impact of being involved in care proceedings on health in the long term, so maternal mortality and other morbidities. So thank you very much for listening, and I've included some references and acknowledgements below. Thanks.